support in making this scientific event happen. Thank you. It's our small contribution in helping to put Bahrain's excellent medical care on the international map. Last but not least, I extend our appreciation to all our sponsors today for their overwhelming support in their participation in today's event.
To invite international speakers as well as speakers from our region to ensure a highly scientific program covering various aspects of rheumatic diseases in addition to osteoporosis. Working as a team at the International Hospital of Bahrain, orthopedic surgeons and rheumatologists work hand in hand to ensure excellent integrated quality of service to our patients suffering from different rheumatic diseases.
Morning, everybody. Dr. Zia, Honorary Chairman and President of the conference and President and CEO of the International Hospital of Bahrain, distinguished guests, speakers, ladies and gentlemen. It gives me a great pleasure today to stand and welcome you all to the first International Rheumatology Conference organized by the International Hospital of Bahrain, which I hope will be carried out every 2 years, and every time we'll choose different topics and we put a different agenda to go ahead with what is happening in the field of rheumatology and immunology. Ladies and gentlemen, before I conclude, I would like to thank two people who were instrumental in working very hard to make this conference a success, Dr. Neil Hanna and Mr. Chris Lewis, and the team of the International Hospital of Bahrain who worked closely with them, inspired by the encouragement from Dr. Zia. Distinguished speakers, I thank you for coming all the way to give your presentations here. At the same time, I would like to thank our honorary guests who are with us this morning, and I would like to thank the audience for attending and coming, and wish all of us a very scientific meeting. Thank you very much.
It's something that we live every day in our outpatient clinics. And here you see the complexity. You know, Sjögren's syndrome actually can be everywhere in all this scenario. This is like a galaxy. And in the center you see MCTT. So all around you see SLEs, scleroderma, myositis, and rheumatoid arthritis. And here there is a fact. If you look at this chart, you are precisely seeing that it is something that can really help you when you are in the clinic to understand where to position a patient. And this important hematological side are autoantibodies. And autoantibodies, and I will not now read this chart, but antibodies can help you to understand not only where to position the patient and which is the diagnosis, but in particular, what could be the prognosis of these patients. Then we have what we know, rheumatoid and SLE again. It's called the lupus syndrome. Usually this is a symmetric arthritis. It's erosive because we know that there are patients that will remain MCTD in their evolution and will not evolve to other diseases. However, we know that there are approximately 30–40% that will evolve to another disease.
First, about the concept of treatment to target. Everyone in his practice, whenever treat any disease, is having a target in his treating this patient. And it should be the primary goal of the rheumatoid arthritis treatment. Today, the remission is achievable goal in patients with clinical, in many patients in clinical trial and clinical practice. It's very important that we attain remission as rapid as possible, because that will result in a better outcome of the patient. And I want to emphasize this, that it has been shown that if we start the treatment of rheumatoid arthritis,
another advanced osteoarthritis of the carpometacarpal joint, and one very popular procedure and very simple procedure is to simply remove this bone called trapezium and just leave a gap there. Some people fill the gap with a tendon. Sometimes you leave it and just sew up the capsule. And it provides good pain relief, good mobility, and reasonable stability.
And we have to realize something here, that normally the diameters of the spinal canal, when we deal with it, we deal with the transverse diameter and the sagittal diameter. In the normal person, there is no correlation between both. But in the pathological one, there will be. In terms of what? For instance, if we took the C5 vertebrae, here is the widest part of the spinal canal in the transverse diameter. Neurogenic intermittent claudication is the most common, and it is the mainstay in the diagnosis, the clinical diagnosis of canal stenosis. In cervical region, what we will have cervical myelopathy, because we have the whole cord, the entire cord passing through the cervical canal with whatever subsequent to. And I have to tell you that even the ataxia, because of the affection of spinocerebellar tract, it can be part of the symptomatology of cervical stenosis. The osteoclastic activity in the bone, it inherits the osteoclastic, which means that to some extent it might reduce the blood perfusion at the osseous level. And from this, we will talk about the mechanism of action. Calcitonin found in fish, birds, and mammals. Of course, the one in salmon is more potent than the human one. It's available and cheaper.
On the same patient, the other side, 10 years ago, the shoulder resurfacing, the shoulder hemiarthroplasty, shoulder hemiarthroplasty, and later on she had a fall, and it's a typical position where the fracture appears at the tip of the stem. So we have a special plating with a circular wire. Also, you can do this in combination with a metal shell in depends of the situation. This one case, now we have here the big head and only the polyurethane buffer behind is not visible in the X-ray. And this is the metal shell and the buffer is a liner inside.
My name is Dr. Faisal Sakabi. I'm a consultant rheumatologist at Kuwait. In Kuwait, actually now we have up to 16 rheumatologists, consultant rheumatologists, 4 adult, 4 pediatrics consultant rheumatologists, and 12 adult rheumatologists. All of us have been trained in North America, in Canada or USA or both. For this reason, many of the drug companies, they try to figure out a way to stop this gas gate, and they start the production of what we call the biological DMARD, like NTTNF in different forms, and even they go advanced in interleukin-6 inhibitors.
Again, there is activity, there is color within the synovial thickening, so it is easily can be diagnosed. Again, this is active inflammation within the tendon. Tendon surrounded by hypoechoic tissue. This again, according to the size of this tissue, you can say how more severe the activity, how more severe the inflammation or the synovial thickening.
To the standard of medicine rheumatology in the country, and we look forward to having more of this. We still have tonight, and I kept it short for you. And there is partying and eating tonight, and I think you should have a little bit of charging of your batteries so that we all will be there. I'm really very, very grateful to you. We're honored to have you here and continue to support us to make this country a better, and to make medicine in this country better, to contribute to it, and to work together in a loving, synergistic way, and for you to set the example. Thank you very much indeed.